My name is Ross McQuivey. I'm the Chief Medical Officer at Clinical Innovations, as well as an adjunct clinical faculty member at Stanford University's Department of Obstetrics and Gynecology. Early in my career, I had the privilege of working under the tutelage of Dr. Aldo Vaca. Dr. Vaca is one of the most visionary physicians as it relates to vacuum-assisted delivery. And his approach to vacuum and the way he trained and the techniques in which he taught were very different than anything I had been exposed to during my training or afterwards. And as I've adopted what I like to call the Vaca techniques, I've seen a tremendous change in my outcomes as well as the success of my delivery. It doesn't surprise anyone that our cesarean section rate has reached an all-time high. Although the ultimate or ideal level of cesarean delivery is really difficult to know, in 1985 the World Health Organization recommended a national rate not to exceed 10 to 15%. In a more recent article published in JAMA in 2015, national C-section rates up to 19% have been shown to prove or associated with lower maternal and neonatal mortality, but there was no evidence to support rates above that. Despite this evidence, we know that the U.S. cesarean section rate has increased sevenfold in the past 25 years. It actually peaked in 2009 at 32.9%, seeing a slight decline over the last 5 years at 32.2% with the most recent data. Now, maternal and neonatal morbidity secondary to cesarean section is well documented, but there are many covariables that are involved, and oftentimes the morbidity is thought to be due to greater proportion of high-risk pregnancies that are delivered operatively. With that in mind, if we look at the trend of operative vaginal deliveries and their relationship to cesarean sections, I think it's important to understand that as we see the increase in cesarean sections occurring at about the turn of the century, that was slightly preceded by the most dramatic decrease in operative vaginal deliveries in the United States. Certainly, there is a relationship here that I think deserves attention. To drive that point home, in 2014, the American College of Obstetrics and Gynecology, as well as the Society of Maternal Fetal Medicine, published their obstetrical care consensus detailing techniques to reduce the cesarean section rate in their safe prevention of primary cesarean delivery. In that particular document, they pointed out that operative vaginal delivery by experienced and well-trained physicians should be considered as an alternative to cesarean delivery. Thus, training and ongoing maintenance of practical skills related to operative vaginal delivery should be encouraged. So today, it is with pleasure and excitement that I get to talk to you about how we can improve our technique and our training in vacuum delivery. Proper training starts with appropriate knowledge of the procedure. Not only the outcomes, but the technique involved, as well as the prerequisites to the delivery. When we start with outcomes, it's important to understand that the chignon, which is just interstitial fluid drawn into the scalp actually takes the form of the cup, will form on the infant's head. Most importantly for parents, we need to make sure the parents understand that this effect of the cup will go away within a matter of hours. There is a benefit to the chignon, and that is that it decreases the overall pop-off or detachment rate of the cup. In fact, the literature shows that with non-chignon producing soft-styled cups, the pop-off rate is between 30 and 35%. But with the hard, low-profile chignon producing cups, it's 10 to 12%. When you begin adding characteristics that we're all very familiar with in the deliveries in which we do, such as molding, caput, or excessive hair, you can see that the pop-off rate actually increases with the non-chignon producing soft cups to 40 to 45%, almost 1 in 2. Whereas the chignon producing low-profiled hard cups remain 10 to 12%. So there truly is a benefit to the development of the chignon. Now, other outcomes include scalp abrasions as you see pictured here. Take my word for it, none of these cups were properly placed. And with proper placement and proper technique, we can avoid these types of outcomes. The other complications that are most often reported in the literature when comparing vacuum to forceps include superficial abrasions, as you saw in the slide before, retinal hemorrhages, neonatal jaundice, as well as cephalehematomas. It's important to understand that one, all of these are what I consider non-significant, meaning they have no long-term sequelae associated with them. These babies can go home. All of these injuries will spontaneously resolve. The other important factor to realize when viewing this slide is that the smaller numbers on the left-hand side, the single-digit numbers, are those of my mentor, Dr. Aldo Vaca. So clearly, whatever he was doing was different than what the rest of the world is doing in their vacuum-assisted delivery. And so whatever he was doing, we want to recreate because he had lower rates of injuries. Now, I think it's also important to differentiate the cephalohematoma, which is benign, and the more serious subgaleal hemorrhage. Now, residents, take note, this is a very, very common board question. So realize with the cephalohematoma, it occurs on the scalp, but it occurs underneath the periosteal layer. Remember from your anatomy that the periosteum envelops each bone in the head individually. That means if the bleed occurs on the right parietal bone, it will not cross suture lines. The bleed will stay confined to that right parietal bone. That's clinically significant because the amount of blood that can be lost in that space is limited. On the other hand, the subgaleal hemorrhage, which is also a bleed on the scalp, is on top of the periosteal layer. It sits between the periosteum and the aponeurosis. And the aponeurosis connects at the eyebrows and the nape of the neck, which leads to the total potential space underneath the scalp that the baby can bleed into. This is significantly different than the cephalohematoma because the amount of blood that can be lost in that space. So clearly, the subgaleal hemorrhage needs to be differentiated from the benign cephalohematoma so that that baby can be treated appropriately. Now, these next couple of slides are just images of one, a cephalohematoma, and the second is a subgaleal hemorrhage. Again, remember that the differentiating factor is the swelling, edema, or blood accumulation will cross suture lines in the more serious subgaleal hemorrhage. Now, if we talk about the rate of significant injuries associated with the use of the vacuum, it's important to understand that they're very rare. The rate of subgaleal hemorrhages has consistently been less than 1% or less than 0.5% for the last 30 years. So if one reports or has experience with subgaleal hemorrhages that are greater than that rate, then we really need to stop and reassess what we're doing. Intracranial hemorrhages and skull fractures, although occur occasionally, they're even less common in those situations. What's important, I think, for everyone to understand in using and utilizing a vacuum device appropriately is that these types of injuries are often associated with three things that we can control in our practice. And what I mean by that is when there's one of these types of injuries, there either has been one, the cup has been misplaced, not on what we'll define as the flexion point, there's been excessive traction or excessive numbers of pulls, or the cup has popped off multiple times. And today I will share with you techniques to reduce those from occurring every time. So the question really becomes, can we avoid these complications? Or should we continue to see and allow the cesarean section rate climb and watch our operative vaginal delivery rate fall to 0? Certainly, I don't think that is the appropriate approach. I think using the device correctly is the key. And when we talk about technique, the first thing we want to talk about is location. Location is the key to the success and to the safety of the delivery when we're talking about a vacuum-assisted delivery. That key location is called the flexion point. It was defined by my mentor, Dr. Aldo Vaca, in the 1990s in his original handbook on vacuum delivery. The flexion point is defined as 3 centimeters forward of the posterior fontanelle along the sagittal suture. And now, as long as we can get the center of our cup on that spot, it will promote the smallest part of the baby's head to present along the axis of the birth canal. Thus, the least amount of force will be required to conduct the delivery. This has a much longer history than the 1990s because if one goes back and looks at the cardinal movements of labor described by Rydberg in the 50s, you'll realize that the mento-vertical diameter, as you see pictured here, the longest diameter of the molded shaped head, will follow the axis of the pelvis according to Rydberg. And babies will descend in the pelvis in not a static position, but will change position as they descend and flex and engage and internally rotate. That movement is trying to realign the mentovertical diameter in the axis of descent. And as we all know, the birth canal is not shaped in a straight line, but it's shaped like a J. So that head has to accommodate the curve of the maternal pelvis, thus make those dynamic position changes. It's interesting to note, and it is no fluke, that the mentovertical diameter happens to cross the sagittal suture approximately 3 centimeters forward of the posterior fontanelle along the sagittal suture, the flexion point. So what we're trying to accomplish with every single delivery is just recreating the stalled mechanism of labor. In what I think is a landmark study by Dr. Aldo Vaca, the importance of the flexion point is very well demarcated. For several years, he had each of his registrars or trainees mark after the delivery where the cup was placed on the fetal head. What he found was quite interesting. When the cup was found to be in a flexing median application as pictured here on the slide, the failure rate of that delivery was approximately 4%. Now this is with all deliveries. This is not just the lift out easy outlet deliveries. This includes even mid-pelvic rotational deliveries in the hands of the trainees, not the master himself. So the key to this high degree of success was due to proper placement of the cup. In fact, this is shown clearly as the cup is inadvertently placed in different positions on the fetal head. This next picture demonstrates a flexing paramedian application, which is when the cup is slightly off the sagittal suture. It's back far enough, 3 centimeters forward of the posterior fontanelle, but it is not midline on sagittal suture. What that does is just increase the dimensions of the fetal head, maintaining or increasing any asynclitism that's present, requiring more force to be used to deliver that baby because of the greater surface area now being presented to mom's perineum. And as a result, you can see that the failure rate went up to 17%. Which is more in tune with what we typically see reported in the literature. Now the next slide will demonstrate what we call the deflexing median application, which is that the cup is properly placed over the sagittal suture, but it's too close to the anterior fontanelle. Now this is the most common application in those difficult deliveries in those OP babies, those babies who are facing up in sort of that military position. One has difficulty getting the cup back in proper position, so they place the cup where they can, which ends up being way too far forward and doesn't do anything to the problem. The problem with that baby is it lacks flexion. But when we place the cup in this position, it doesn't encourage or allow the normal flexion or chin to chest movement to occur. And as a result, we try to drag a very large anterior posterior diameter of the fetal head through the maternal pelvis. And as Dr. Vaca showed in his data, the failure rate now is approaching 30%. Last but not least is the deflexing paramedian application. So not only are we too far forward, but we're off the side of the sagittal suture, increasing the dimensions of the fetal head in all directions, which is going to obviously increase the force required. And as such, the data showed that Dr. Vaca's failure rate, or his trainee's failure rate, was 35%. So the key is getting the cup properly positioned on the flexion point to help guide the smallest part of the baby's head through the maternal pelvis. Thus, remember, whenever approaching a vacuum delivery, it's not about dragging anything out. It's not about an extraction. This is not a tow truck. Vacuum was designed to be a front-end realignment tool, to place the cup on the ideal location on the fetal head and guide the smallest diameters along the axis of the pelvis. As you know, there are a plethora of vacuum devices that are out there available to us in our practice. It's important to realize that there are two key differentiating features of any vacuum device. And that is, one, does it have a rigid, centrally located stem? Or two, does it have a low-profile cup with a maneuverable stem? The key is being able to get the cup properly positioned over the flexion point, and that is best done and enhanced by using a maneuverable cup as you see pictured here. To better demonstrate this principle, I'm going to use a pelvic model to show you the differences between a rigid stemmed cup that's centrally located and a maneuverable low-profiled cup. To emphasize the difference between rigid stem centrally located cups and the more maneuverable low-profiled cups, I'd like to demonstrate using this pelvic model. If we place this baby straight occiput anterior and at the outlet, you'll see that the flexion point 3 centimeters forward of the posterior fontanelle, a long sagittal suture, essentially is my presenting part. So I could take any cup on the table, rigid stemmed or not, and place it on that spot and essentially get that baby delivered with little effort. As you know, babies who need our assistance rarely present straight occiput anterior and at the outlet. But let's make it a little more realistic and put it in a low station and add just slight rotation so it is left occiput anterior. Now this is still a delivery in which I'd let my intern do, but notice what it's done to the presenting part and what it's done to the flexion point. Presenting part now has become mainly the right parietal bone, and the flexion point is actually moved down 3 centimeters along sagittal suture away from where we can get access by using a rigid stemmed cup. If we place that rigid stem cup on this spot, you can see that we're essentially placing it on the majority of the right parietal bone of the fetal head, and we're trying to drag the baby down in an oblique fashion, not in the axis of the pelvis, which is going to require more force and increase the chances the cup comes off and causes scalp lacerations or abrasions. Now, some people say that you don't give this cup enough credit, and one of the benefits of the soft design is that you can collapse them. And perhaps you could collapse the cup enough that you could move it so that you could get it over that so-called flexion point. The problem with that is this: there's not a physician in this room or listening to this lecture who would pull in that direction to deliver this baby. We obviously all pull along the curve of Caris or along the axis of the pelvis, which is in this direction. The only problem with that is rigid stemmed cups are designed to be pulled at 90 degrees from their attachment. So as soon as we try to pull in the axis of the birth canal, we end up popping the cup off and causing abrasions. Now, the beautiful part in the design of the maneuverable cup, what it allows us to do is we don't have to leave the cup in that position on the presenting part. We can actually slide the cup down over the flexion point and then let the stem follow out of the introitus. And because it's not a rigid stem, as we pull in the axis of the pelvis, it doesn't create a vector of force that's going to pop the cup off, but essentially is going to guide that baby's head along the axis of the birth canal. So in the occiput posterior position, again, the presenting part becomes the anterior fontanelle. The posterior fontanelle is all the way back here, and the flexion point is just 3 centimeters forward here. So by using a rigid stemmed cup, we're essentially forced to put it here, which is way too far forward over the anterior fontanelle, which does nothing to the problem of this baby. The problem with this baby is it lacks flexion. It does not have chin to chest mobility or movement, and so it presents a very large anterior-posterior diameter of the fetal head to the maternal pelvis, which is going to require more force to bring across the perineum. Now, even with an incredibly ugly rectoepisiotomy that mom could never forgive me for, I still couldn't get that cup in proper position. The beautiful part of the maneuverable stemmed cup is what it allows us to do is not leave it here on the presenting part, but actually push it back over the flexion point and then let the stem follow like a tail, so that when I provide traction in the axis of the pelvis, I'll actually encourage that chin to chest movement or flexion of the fetal head that'll present the smallest diameter of the head to the maternal pelvis and allow the normal process of labor to take place. Now, I hope that makes it clear that the key is being able to take a maneuverable stemmed cup and get it over the flexion point every single time. The other parts of technique that are important are obviously the method of traction, which should be constant and smooth in the axis of the pelvis when mom pushes, which means as mom stops, we stop our pulling effort. Sometimes that can lead to confusion, and what I mean by that is pulls are not counted according to the maternal effort, but pulls are counted only according to the contraction. So if mom has 2 or 3 individual efforts during one contraction, that is still considered one pull. We should also remember to avoid any sort of rotating or side-to-side movements of the device, realizing that the axis of the pelvis moves in one direction, and that is along the curve of Caris, and that is the direction and the only direction in which we should pull. Now, one of the common mistakes is that oftentimes many of us, and I did this quite often, much to Aldo's dismay, is we tend to pull upwards too soon. And what I mean by that is we all understand that this baby is going to eventually deliver across the perineum by extension. So we want to help the head extend by pulling upwards. But realize that the widest part of the fetal head, or the widest diameter of the fetal head, is the biparietal diameter, which sits 6 to 7 centimeters behind our cup. That means if we see the cup at the introitus and begin pulling upwards, you will begin to pull the head up into mom's pubic arch and eventually pop the cup off. So don't get in a hurry to pull up too soon, and we will demonstrate that today on our model. This really stems from, and if you're like me, you trained on forceps, it comes from the use of forceps because we have to make a dramatic change in our traction with forceps in order to prevent any of those sulcus tears caused by the toes of the blade. But remember, the forceps sit in a very different location, as you can see pictured here, than the vacuum does on the fetal head. Now, the non-pulling hand is just as important, if not more important, than the pulling hand. And what it's going to do is provide counter traction. What Dr. Vaca would always encourage is for one to put their thumb on the cup and rest their finger on the scalp. The thumb provides counter traction, pushing back against the fetal head, and the finger rests on the scalp to monitor true descent versus just scalp movement. So always maintain a finger-thumb controlled position on the cup anytime you provide traction on the fetal head. This will decrease the chance of any of those unwanted and dangerous pop-offs. Now let's take a moment and just talk briefly about pop-offs. There are really 2 classifications or 2 categories of pop-offs that I consider. One are preventable causes and the other is non-preventable causes. Preventable causes include misplaced cup not on the flexion point, excessive traction, inappropriate axis of traction, maternal tissue being trapped under the cup, inadequate vacuum level, not pumping it up to the top of the green, poor maternal effort, as well as faulty reusable equipment. All of those can be prevented with proper technique in which we're talking about today. Non-preventable include caput, molding and edema, or excessive hair on the baby's head, large babies greater than typically 4,000 grams, or primogravid patients. Now, that's not to say that those particular characteristics are contraindications to the use of a vacuum. That is just to say that in the face of those characteristics, our technique has to be even better to decrease our chances of the unwanted and, as you'll see later on, dangerous pop-offs. To finish with the theory of vacuum, remember that it's all about restarting the normal process of labor. The cardinal movements of labor, as we learned in medical school, include descent, engagement, flexion, internal rotation, continued descent, extension, and external rotation of the head with the shoulders. Now, this is just to remind us that with vacuum, this is what we're trying to do, is recreate the stalled mechanism. Thus, the idea of rotating a baby with a vacuum is not placing a cup on and trying to manually rotate or force the baby around, but it's actually to go in and correct the problem. In those babies who lack rotation, an OP or an OT baby, what typically has happened in those situations is they've become deflexed or maintained their lack of flexion, or they've become asynclitic. And the goal with proper placement of the cup is not to cause rotation, but to actually correct the deflection or correct the asynclitism. As such, as those are corrected, then the next mechanism of cardinal movements will occur on its own spontaneously, which include internal rotation. Again, we will demonstrate this today. Now, to be honest, I had heard all of that when I was in training, actually by listening to Dr. Aldo Vaca at a grand rounds on one particular day. And I went out with renewed vigor to try to recreate what he was talking about and increase my success of vacuum delivery. And unfortunately, I didn't have much more success than I had previously, and I went back to using my forceps. Eventually, I had the opportunity to work with Aldo hand in hand. And the first thing that he asked me was, what cup was I using? Now, I anticipated that question, and of course I knew the answer, and I told him I was using his, the Kiwi Omni cup. And he said, great, then you're using the marks on the stem. And that's where he had me. At that point, I had to look at him and say, what marks on the stem? Well, on every Kiwi Omni device, there are marks at 6 and 11 centimeters, and those marks are actually vitally important to our success of being able to get our cup properly placed over the flexion point. As you can see pictured here, when this particular baby on the left-hand side is in a transverse position at that particular station, you can see that the distance from the flexion point where the middle finger sits from the examining hand to the perineum or the posterior fourchette is approximately 6 centimeters. However, on the one to the right, the baby is up in a little bit higher position, more of a mid-pelvic station, and is in an occiput posterior position and deflexed. As such, the distance to the flexion point is much greater. In fact, you can see it's represented at 11 centimeters. These marks are going to help you get your cup properly positioned over the flexion point if you take the time to measure the distance between the flexion point and the perineum. So I'm going to share a video with you that is going to demonstrate this process. To demonstrate the best practice of consistently getting your cup on the flexion point every single time, it's important to understand what Dr. Aldo Vaca was talking about when he emphasized measuring the distance from the posterior fourchette to the flexion point. Now, we all have a natural ruler on our hand, or a measuring instrument, and that is if we know the distance from the middle finger, examining finger, to that interphalangeal joint, you'll see that it is between 5 and 6 centimeters, and to the metacarpal joint on the hand, that's between 10 and 11 centimeters. If we understand that, during our vaginal exam, we can determine the distance from the flexion point to the perineum, or where the posterior fourchette comes in contact with your hand. Now that is to reference the marks that are found on the Kiwi Omni cup. On every Kiwi Omni cup, there are marks that are found on the stem at 6 and 11 centimeters. Those marks are to coincide with the marks that are naturally found on your hand. The other key point to realize is that the flexion point has a tendency to stay in the midline. Now, this is very counterintuitive to many of us because we're used to saying a baby's left occiput anterior or right occiput posterior, and thus our assumption is that that flexion point must be off to the maternal right or the maternal left, depending on the position. However, as you can see pictured before you, regardless of the baby's position, whether it be in a right occiput anterior or a left occiput posterior position, the flexion point really stays in the midline of mom. And that is, although counterintuitive, very key to our success, because once we start pushing the cup back in the distance, whatever we've measured with our hands, you want to avoid the natural desire of moving the cup to the left or to the right based on position, because realize what is left or right is the occipital bone, not the flexion point. The flexion point is 3 centimeters forward of that position. So remember, the key to placing your cup correctly over the flexion point has more to do with the distance measurements than pushing your cup left or right. Now, how do we simplify all of this? We've spent the last 20 minutes talking about proper technique. How do we really simplify this? What Dr. Vaca did late in his career was create a 5-step technique that is proven methodology to increase your success of the delivery. And this is what I want to concentrate on with you today. My goal is that when you leave, you will be able to confidently walk through the 5 steps on any of the vacuum deliveries in which you do from here on out. Number 1, and the most difficult, is locating the flexion point and calculating the cup insertion distance. And it's the most difficult because, as you know, in these babies who need assistance, there's oftentimes caput, molding, and edema that makes that exam difficult. But as you know, any contraindication to any vacuum delivery is not knowing the position of the fetal head. So we have to be able to determine position, and from that we can find the location of the flexion point and determine the distance to the posterior fourchette. Step number 2 is to hold and insert the cup, and I will demonstrate that in a moment in the video. Step number 3 is to maneuver the cup over the flexion point. Again, I will demonstrate a 2-finger technique that Dr. Vaca promoted. Step number 4 is to create the vacuum and exclude maternal tissue. And step number 5 is remembering to pull in the axis of the pelvis using the non-pulling hand, which is the thumb on the back side of the cup and resting the finger on the scalp. Step number 1 is to check position and station of this baby. In this instance, this baby is right occiput posterior at +1 station. Now I find the flexion point 3 centimeters forward of the posterior fontanelle along sagittal suture. I rest my hand on the perineum and I determine from the middle finger to that part of my hand is approximately 8 centimeters. Step number 2 is to hold and insert the cup. So place 1 finger in the vagina or 2, pulling downwards to create room, and then sliding the cup on its side as small as possible. Once it's flat against the fetal head, rotating it up flat, and then removing your hands. In step 2, when placing the cup, the easiest way of keeping track of the groove is to place one's thumb on the top of the groove. When the cup is inserted into the vagina, the groove goes in at 9 o'clock, and then as the elbow is rotated upwards, the groove is naturally placed at 12 o'clock. Step number 3 is to maneuver the cup to the predetermined distance, which in this baby was 8 centimeters. So I insert 2 index fingers, the superior hand holding tissue up and out of the way, the inferior hand right up on top of the edge of the cup and pushing downwards. As I push down, you can see the stem shortening. I'm now at the 6 centimeter mark, and I continue to push. There's 7 centimeters, and there's 8 centimeters. I hold or stabilize the cup with my superior hand, and I use my other hand to establish vacuum. Step number 4 is to establish vacuum and also exclude maternal tissue that may be trapped underneath the cup as the vacuum is applied. Step number 5 is to place the thumb on the cup and the index finger on the baby's head to prevent that cup from coming off and providing countertraction during our pulling efforts. As mom begins to push, we will provide our traction in a downward angle in this baby who is right occiput posterior. As the baby gets further and further down in the pelvis, notice the direction of pull changes until I begin to finish here as the baby reaches the perineum, and you can see where the cup was placed. There are 3 whens that we should all be very well versed in when approaching a patient for a vacuum delivery. The first is, when do we use it? The second is, when do we not use it? And the last one is, when should we quit or abandon the procedure? When to use it is pretty easy, and what I mean by that is we refer to the ACOG Practice Bulletin number 54 that was published in November of 2015. That has been consistent, and it remains the same as forceps. There are 3 key indications for the use of a vacuum. Prolonged second stage of labor, regardless of your definition. suspicion of or a non-reassuring fetal heart tracing. Shortening the second stage for maternal benefit most often is exhaustion, but could also include a maternal pathology that does not allow a mom to push during the second stage or for long periods of time. Thing to remember about that last one is vacuum, again, is not an extraction. We need maternal effort. So we need to make sure that mom provides effort in pushing and that she's able to push. We may just have to limit the time that she pushes. If she's unable to push, then vacuum is not indicated for that particular case. Contraindications include prematurity, typically defined at less than 36 weeks, although you will find some limited literature less than 34 weeks. Live fetus is known to have bone demineralization or bleeding disorders such as hemophilia or osteogenesis imperfecta. Fetal head not being engaged and cervix not completely dilated. Those are practices of the past. It wasn't uncommon to use vacuum in those situations many, many years ago, but obviously a contraindication in today's medicine due to the complications associated with those techniques. Cephalopelvic disproportion, if it's suspected or known. I rarely found a case where I know it's CPD, but if there's a suspicion, then we need to be wary of doing this delivery. And then last but not least, as written in the ACOG bulletin, unknown position of the fetal head. The most important one is this next slide, which is knowing when to say when or abandon the procedure. There are 4 suggested guidelines that Dr. Vach introduced to me very early on in my career with him. And I encourage you to adopt these guidelines as well. The first is if descent does not occur with each pull, meaning if I put my cup on and I pull and it feels like I'm pulling against that wall, then I need to stop and reassess my position, my direction of pull, and the choice of my patient. I should be making progress with each pull. If not, I should stop and reconsider the procedure. Now, if delivery is not achieved or imminent after 3 pulls, now that's the typical or the standard rule, but as you can see there, I put a question mark there, and that is this. If you look at the literature, if you abandon a vacuum delivery after 3 pulls, you will leave approximately 35 to 40% of your babies undelivered, although many of those are on the perineum and ready to be delivered. So the key is we need to make sure that we differentiate or we understand what imminent is. If it truly is on the perineum and I can get this baby delivered with 1 or 2 more pulls, then that's what I would consider or encourage. If I can't, if the baby's still in the pelvis and my progress has not been as what I've expected, then I need to stop. 15 to 20 minutes, most babies are delivered with a vacuum in less than 12 minutes. So 15 minutes, you're getting into the caution zone or the yellow zone. 20 minutes is the red zone. Encourage you not to go beyond 20 minutes because of the increased risk of complication. And then last but not least are pop-offs. Pop-offs were originally thought to be a safety mechanism. And what I mean by that is if one pulls too hard with a vacuum, the cup will eventually come off. And so there was many in the past who thought that this process was a safety feature of the device, an inherent safety feature. However, as you can see with this demonstration, that negative traction and that stress that's caused by pulling the scalp away from the skull just increases the chances of complications. And then that sudden violent detachment that occurs is what leads to those complications, including subgaleal hemorrhages, which are rupture of the emissary veins in the scalp. Last but not least, we should avoid using forceps after a failed vacuum delivery. If we failed with one operative vaginal delivery technique, we should go to the back and deliver the baby through the abdomen because of the data that shows an increased risk of significant complications associated with that so-called sequential delivery. So to summarize the techniques that are most important in our successful vacuum delivery, it's 5 steps. Correct cup application is number 1, determining that position and then maneuvering our cup over the flexion point. Pulling along the axis of the pelvis using the finger against the cup and our thumb against the cup and our finger against the scalp. And last but not least, having it clear in my mind, if I reach one of those spots, I'll take the cup off and I'll go to the back. So my conclusions are these. First, I believe that our cesarean section rate is too high. And we need to make a concerted effort to provide C-sections to those who are in need of a cesarean section, but also to advocate for rational use of the procedure. And one of the most effective methods of reducing our cesarean section rate is implementing proper vacuum delivery techniques, so that when we approach a patient in the second stage who's appropriately identified as a candidate, that we can be successful in our attempt of that operative vaginal delivery. Remember that the success and the safety of any vacuum device is placing that cup properly over the flexion point, 3 centimeters forward of the posterior fontanelle on the sagittal suture. And also recall the Vaca 5-step methodology, which is proven and should be accepted or adopted nationwide and taught to everyone so that we can be successful in our deliveries. Thank you very much.